Yeah, yes, we can get going. Good morning, everybody. Okay, this is a patient with WPW in the cath lab, and this occurred. So what happened, and what is the significance of what we're seeing here? So why don't we go to Dr. Marshall.
Good morning. Let's see.
This is a case I did many years ago.
So we have one beat here on the left, and then there's a pause. And then just looking at the right of the screen in general, you just see there's a lot going on, but trying to first
Just look at your channels.
yeah. So starting at your high right atrial catheter,
Mm-hmm.
it's very fast.
Yep.
So to me that strikes, were you pacing before this or no?
I think this is an RV paced beat,
Okay.
and then I guess the pacing stopped and
Yeah, and then this
started.
happened. Okay. So just looking at the high right atrial catheter first, it looks like you have some type of atrial tachycardia. Um,
Any thoughts on what type?
my thought is, and especially with the type of patient I mean, it doesn't look, so my two thoughts are if it's, I mean, knowing that this is a patient with WPW, what you're, concerned and thinking about is um AFib that conducts, but it doesn't look irregular, which is where I'm pausing a little bit at the beginning.
Well,
It changes though, like about halfway through.
right. Also,
So
what's going on here?
uh you're saying in the hiss?
No, I'm like all over the place. Is
No,
it?
yeah, it's just like, I mean, it looks disorganized there, I guess, to your point. So are you suggesting this is fib then?
Yes, I am.
But why does it, my question is, because like to me, the rate looks, that like my thought was either it's fib or flutter, and knowing the type of case, we're worried about being fib, but why does it look so regular at first in the HRA is where it was giving me pause.
Right. Well, because when you're in atrial fib, the entire atrium is not necessarily doing the same thing at the same time.
Uh-huh.
So if you look in the CS pairs, which represent, of course, the left side of the
Hmm.
area, right, it doesn't quite look the same, right?
Yeah.
Right, like we know these are the V's, right? So
Yeah.
most of this is atrial activity in here, and it's not quite corresponding exactly one for one. So it kind of looks like there's zone action going on the left atrium and different action going on in the right atrium.
I see. Okay.
And although I agree with you completely that it looks sort of regular, I think if you took calipers out, you would see that,
Probably wouldn't
like,
be.
yeah, this RR is not quite the same as this
Yeah.
RR. And then of course down here it looks even less
Right.
regular, right? It looks
Yeah.
quite irregular here. So this is just kind of like spontaneous atrial fibrillation. And what can we glean from the AFib, right? Because anybody could go into AFib. Um, Although we do think that people with WPW are more easily able to go into AFib. Mm. But with this, so the fact that we get AFib is not, not especially surprising. It's a little unusual that it happened kind of spontaneously, but that's okay. But I guess the question is, can we glean anything regarding risk in this patient based on this tracing?
Um, let's see.
So we do know that they can have AFib. So that
Yeah,
can
they've
happen,
demonstrated that they can do that.
which some patients, we try hard in the lab and we can't even induce fib, but in this case, it kind of happened almost by itself.
So,
But is this a high risk, low risk, or medium risk?
right. So you
What
want to
is
go
what is high? What is low risk? What would low risk be?
low. I mean, do you consider low risk if you can at all? Or I'm used to thinking about it from high risk versus not, but I'm not sure if there's another line in the sand for low
Yeah,
risk.
so anything under 200 beats per minute or 300 millisecond cycle length would be considered low risk.
Okay. And then lower than 250 is high risk. So then you have that like kind of intermediary zone.
Right. And unfortunately, as I often explain to patients, most people end up somewhere in the middle
Mm-hmm.
where we can't just, can't say, again, these are based on adult data in awake patients. We don't really know how how applicable they are to kids, but these are the numbers that we use. So yes, cycle length less than 250 is usually considered high risk. Cycle length, greater than 300, low risk. Somewhere in the middle is sort of, we'll call it moderate risk. So is this low, moderate, or high risk?
Well, it looks like I have some hints at the top, and that one number is 190. I mean, so I would say high risk based on that one.
Well, there's calipers on the screen. Somebody was nice enough to measure something. What is that person measuring?
Oh, I didn't see that number there either. Sorry, I was looking at the numbers you have at the top.
Yeah, the
Um,
numbers at the top, this particular recording system would try to measure the RR automatically.
oh, okay. That's what I thought it was.
Yeah.
Okay.
You're
So,
right. You're right. That is what it's doing, but
but it's not the
I'm
best
not
one.
sure how accurate it is. But
Yeah.
here somebody took a caliper out and measured something. So what are they
Yeah. So
measuring?
they're 235 though, so that would be less than 250, so still high risk.
Right. So this is a patient who would be, this is a very nice demonstration of, hi, good morning. This is a very nice demonstration of something we would view as high risk for sudden cardiac death. And can you tell based on this single V-paced beat where the pathway is? A little hard. This is this is second tier or third tier question here. Well, what's happening in the high, is the higher A early or late relative to all the rest of the A's? Molly, you still there?
Oh shoot, I was muted. I didn't realize I was. Sorry. I was like, I said it. So it looks in the high right and after the single V pace, what you're asking, right?
Yeah,
Yeah, it looks later to me.
yeah. And what about the CS's relative to the Hess?
Looks especially where it's earliest, looks tighter.
Yeah, yeah. So like it looks earliest.
It looks tightest or earliest in 7/8. Yeah,
Yeah, yeah.
the
They're almost
lateral.
right. They're almost one beat together. So
Mhm.
CS proximal we know is sort of near the mouth of the coronary sinus. 7/8 is sort of just inside. So this would probably be like a left posterior, maybe paraseptal type pathway.
Mm.
We'd need to get in there and map it to figure out exactly. But the point is, this is a patient in whom we would be concerned for the risk of sudden cardiac death. Um, one of the things that always comes up is, if you pass this test when you're under general anesthesia, does that mean you're okay? And the answer is nobody really knows. And there have been, and there have been studies that have looked at. The other thing is, does 250 really mean anything in a child? Almost all kids' conduction is better than adults. So this 250, which came out of an adult study in which patients who arrested and patients who didn't arrest had awake electrophysiology studies and were intentionally put into AFib. Um, that's quite a bit different, right, than taking a child and putting them under general anesthesia and testing them. So some studies have looked at using isoprel to sort of mimic the effects of having normal adrenergic tone being awake. But I many years ago somebody wrote a paper on this, and I was one of the reviewers, and I was asked to write an editorial, and I just kind of made the observation that you could surmise or you could guess that you can make any pathway high risk if you turn the isopril up enough. So it's always, worrisome to me that we use as a rationale to ablate things, these numbers. And if we don't like the numbers, some people just, turn on the isopril until they get the number they want to ablate it. Now, that said, there are also, in opposite, there are patients who have passed all of these tests, patients who've had AFib induced and have had RR intervals of like 150 beats per minute, almost no conduction at all through the pathway, who've gone on to have a cardiac arrest. There are reports of that in the literature. So I think the bottom line is we don't really know how best to judge risk, but I think what is happening is that as the perception of risk of ablation is falling, people are increasingly ablating more and more on the theory that why would we expose someone to the risk of possibly dying when the risk of the ablation is relatively low. I'm not sure I completely agree with that. I do think there are risks associated with ablation that are not negligible, particularly if you have to go into the left atrium. But certainly an argument could be made either way. It's no right answer on this. All right. Okay, we're gonna name the catheters. So why don't we go to Dr. Kaloff? What do we can go
All right.
from A to D. So what is A?
So I'm thinking A would be the high right atrium.
That is correct. What is B?
Um, B looks like it's the CS. Actually, no, the CS is C.
Uh-huh.
And
What
D is the RV.
Yep. And what is B? We haven't still
Yeah,
settled on
okay.
what B is.
So B would be could be like the mapping catheter or a plating
No,
catheter.
no. What is B? Well, this is the mapping catheter, right?
Yeah. Right.
So what is B though? This is a separate catheter from this. This is an RAO projection of the catheters. This is in your
His, yeah,
area.
his.
Yes.
Sorry, I forgot
Yes.
that.
Yeah, that's the hiss. So so high RA, hiss, coronary sinus. In this case, Dr. Love, I think, did this case, and he used a octopolar catheter that has 4 electrodes, not 4 pairs, not 5, which is fine, of course. And then an RV catheter. Now, here's the extra credit question. Where is the ablation catheter? So why don't we ask Dr. Kaloff again, our resident expert on this case. I understand why you thought that the other was the ablation, but where do you, is this a worrisome location, a not so worrisome location? Where do you think this is?
Is this transeptal?
Transeptal? No. But the word septal is right. Is it close?
The tricuspid, like closer to the tricuspid annulus.
Yeah, it is. And is it close or far from the hiss, you think?
Looks close.
Very close, right? I mean, now we don't see the orthogonal plane here, but it looks really, really close. So this is an example of so this is, I guess, where the pathway mapped to, and you can see that it's very, very close to the hiss. So this is how you would describe this really depends on how it looks in both views, but my understanding is that this was considered to be paraseptal, meaning very, very close to the hiss. And in fact, in the map, all of the earliest signals were pretty much exactly where the hiss was. This was a patient with WPW. No, I'm sorry. This was a patient with a concealed accessory pathway that happened to be mapping to the area immediately next to the His in the anterior septal region. Now, how do we normally map concealed pathways, Mohammed? Like I say, okay, now we know it's a concealed pathway. I'm going to map it. So how do we demonstrate conduction through a concealed pathway to map it usually?
So I'm thinking a concealed pathway would be like you would see VA conduction, retrograde VA conduction.
Uh-huh, that's right. So we would typically, right, pace the ventricle, and we would look for the earliest retrograde atrial depolarization, right? And the closer we are to the location of the pathway, the earlier the atrial electrogram would be. So let's just say, for the sake of discussion, if the pathway were located here near the mouth of the coronary sinus, every time I move the catheter, and let's assume like the tricuspid annulus is over here. If I put the catheter here, the relative atrial electrogram is going to be later. And then if I go over here, because I'm getting closer to this area, it's going to get a little earlier and earlier and earlier until finally you get a very early ventriculoatrial timing here, which would suggest you're near to the pathway. And then once you find that location, you might micro adjust and move a little here, see if this is earlier, and eventually you find the spot. Why do you think, though, that V-pacing, why would V-pacing not help you, though, in mapping here? So that is the way we would normally, you're right, that's how we would normally map a concealed pathway that conducts retrograde, is we would V-pace and we would find the earliest retrograde A. And when we have the shortest VA interval and the earliest retrograde A, we would assume that's where the pathway is. We would turn on RF current and we would successfully ablate the patient. But why could we not, why, in this case, if the pathway were really where that ablation catheter is, so close to the His catheter, why would RV pacing not necessarily be helpful?
Because you might get retrograde VA conduction through the His, through the VA node.
That's right. That's exactly right. And that's a very sophisticated answer. You get extra credit for that answer. So if you have a pathway that is sitting on top of the His or near to the His, when you pace the ventricle, it's going to go up both the pathway and the AV node at the same time. And so you are going to get fused conduction in this area, which is going to make it very difficult to map. In fact, you might end up mapping the His or mapping the AV node inadvertently because they're very close to one another. So you really, if the pathway turns out to be near to the bundle of His, you cannot retrograde you can't V-pace and map it because it's going to be going up both, and you're not really going to know which one you're mapping. So how could you separate the two out, do you think?
I mean, we can give adenosine and
Yeah, you could do that. So you're saying give adenosine, you block the AV node, you're pacing the V, and you could map that VA into that VA while the adenosine is on board. You could do that, but right, how many times when we're mapping a pathway, we take like 75 or 80 points, right? So you'd have to give a lot of adenosine, right? And each dose only lasts for like, if you're lucky, maybe 6 or 7 seconds, right? So that's not, so it would work, but it's really not practical. You'd end up using the entire supply of Mount Sinai's adenosine to map it. So, that might be good to confirm like if you've mapped it and you think you're in the right place, it might be worth giving a dose of adenosine to sort of give yourself an extra way of confirming you're in the right place. But it wouldn't practically be good. So I'll give you full credit for that answer, but it's
I think I'm not sure if this is true, but can we try VA pacing while the His is refractory, so you'll only have VA conduction through the accessory pathway?
Well, the only way to do that is if you pace the V so fast that the AV node and the His don't conduct retrograde. So you could do that, but chances are, since you have a pediatric patient, both are going to conduct well, and you probably would have to pace so fast that the patient may not be stable. You have to pace at like 230 beats per minute or 240 V pacing. That's going to cause anybody to be hypotensive. So if I did that, chances are the anesthesiologist would, after 30 seconds when they do their routine blood pressure check, they'd say, what's going on? The pressure's down. So that could work. But if that actually worked at a slower heart rate, it would mean that the AV node doesn't conduct so well retrograde. Now, there are people who don't have retrograde AV node conduction. So that could be, that sometimes you get lucky that way. But in children, oftentimes there is retrograde AV nodal conduction. So any other ways that we could only see retrograde conduction through the pathway and not through the node? So you've given me two options. One is to pace so fast that I block the His and can only go up the pathway. That, of course, assumes that the refractory period of the pathway is shorter than the AV node, but that might be true. But we've decided that's not a good practical way because it might require very fast pacing that would not be tolerated. Another option you've given me is to give adenosine to transiently block the AV node in the bundle of His. Well, the third is to induce tachycardia, to induce ORT. In ORT, what is the retrograde limb of ORT, Mohammed?
It's the pathway, right?
It's the pathway, right? So in ORT, you're going down the AV node and only up the pathway. And so in ORT, you can map the pathway very accurately because you are only, when you're going from V to A, you're only basically conducting through the accessory pathway and not through the AV node. So when someone has a paraseptal or a parahiscian pathway or something that's in an area where we think there's a risk for heart block, one option is to induce orthodromic reentrant tachycardia and then map the pathway retrograde during tachycardia. And that works very well, but there is a problem with that. So let's say you do the whole map and you finally decide that this is the location where the catheter is right there, where the arrow is pointing. That's your earliest spot. How will you know, like normally when we are ablating, right, we look to see if the pathway blocks. But if you turn on RF during SV, so the best way to tell, right, would be to leave the patient in ORT, put the catheter up there, turn on the RF current, and if you get the pathway, then tachycardia should suddenly terminate, right? Because you have no more VA conduction. But what would happen, do you think, to the catheter if you go from a heart rate of, say, 220 to a heart rate of 75 suddenly?
Will move from its
Catheter
place.
could move. So two possible things could happen. Either you could have the catheter move out of position because when the heart just suddenly stops like that, the catheter is going to jump. So it could either just jump out of position, in which case you have not delivered adequate RF current to successfully ablate the pathway. But you also, and perhaps more worrisome, is that you could jump into the His and cause heart block. So you would never really ablate somebody. Now, there is one exception. You could use cryo. You could put cryo up here, put the patient in ORT, turn on the cryo, and then when the tachycardia terminates, you could see the catheter won't move, right? Because when we go to minus 80 degrees centigrade, the catheter develops an ice ball at the end and is stuck to the endocardium. But, until the tachycardia terminates, you don't really know if you're on the His or the A, if you're that close, His or the pathway. So some people would say, well, why don't you try using cryo here? You can do it in tachycardia. And if tachycardia terminates, and when you terminate, you're in sinus rhythm, then you're good to go. That would be a reasonable approach. Another approach, what I would normally do in a case like this is if I think that that's where it maps in ORT, I will then terminate tachycardia and I will try to put an RF application or a cryo application in sinus rhythm at that site. Now, the disadvantage is that if I'm doing it in sinus rhythm, I have no idea if the pathway is gone because I'm not demonstrating. If the pathway is a concealed pathway, it can only conduct retrograde. And in sinus rhythm, we are conducting antegrade. But the advantage is because we are conducting antegrade, we can tell if we're causing any AV nodal or His injury while we're delivering current. So I accept the fact when I'm doing a case like this that I may be delivering RF current in the wrong place and that I don't really know how fast the pathway went away by ablating here. But my feeling is that the knowing that the patient's conduction is preserved at all times during delivery of current, whether it's a cryo or radio frequency, is important enough that I'll accept the fact that I might be slightly off. I'd rather know that the AV node is okay. In this particular case, Dr. Love demonstrated that basically the only place where the signal was definitively clearly earliest in tachycardia was at the area where there was a His signal. And so in his view, and I totally agree with him, there really was no sense in trying to ablate there because by everything we understand, the likelihood was very high that the patient could develop heart block as a result of an application in that location. The other thing that you have to remember is that when the patient is in tachycardia, the heart is moving in a certain way, the heart is shaking. And so we map it to a certain location, and on Carto, we mark where that is, and we say, okay, that's the spot. But if I then put the catheter there in sinus rhythm, I may not be in the same place because the heart may not be in exactly the same place because the heart is in a different location slightly by a few millimeters when it's in tachycardia versus when it's in sinus rhythm. So this might be the perfect spot in tachycardia, but that may actually correspond to a location over here in sinus rhythm. So these can be very tricky. I once had a patient who was a young lady who was like a champion softball, fast pitch softball player. And she, every single time she went on the mound, she would have SVT. And she had a concealed parahisian pathway. And twice I brought her to the cath lab trying to induce ORT because I could not map it except in ORT, and I could not get more than a single beat of tachycardia. And ultimately, what happened was just so that I was doing the patient a nice service, I said, look, you know what? Why don't you go to a different electrophysiologist? Maybe someone else will be luckier. I tried to send the patient to Dr. Walsh in Boston. Their insurance did not par. And just showing you what a wonderful guy he is. He came to New York and he did the case with me. And that day, by the grace of God, the patient just had a lot of tachycardia. Just, happened that day. We were able to induce and we were able to map it and ablate it within about an hour. And it actually turned out to be a relatively easy case. But you could see why, if you cannot induce ORT and the pathway is thought to be close to the His, it's very difficult to map a concealed pathway that's paraseptal. Does that make sense?
Yes, thank you.
Yeah, thanks. So I think with that, we're going to stop a bit early. Thanks very much. Hope everybody has a great day. See you in sign out just a little bit.
Thank you.
Thank you.
Thanks, everyone. Bye-bye.